Welcome everybody. It's very nice to see you all here. What we're going to do is talk for about half an hour and run over the main aspects of kidney problems with TSC. I'm going to start and then Nick's going to finish, and then we'll throw it open for questions and answers. Next slide, please, Nick. So this is just the overview of the talk. I'm going to talk about how TSC affects the kidneys, about how things were in the bad old days, what we learned from the Tosca study, then we'll talk a bit about treatment, Access2 and other treatment studies, recommendations for surveillance, early treatment, how we run a TSC service at St. George's. Then Nick's also going to talk a bit about COVID-19 and how that affects both treatment and TSC, and we'll expect a few questions on that. Okay, next slide, please, Nick. So to jump straight in, thank you. Don't worry, this is a bit complex. It just gives an idea of how TSC presents and progresses over the ages, and most of you will know all of this already. But of course, the early problems can be very mild or often quite severe, and heart problems are an issue at the beginning. The brain issues, such as learning disability, autism, epilepsy, all occur very early when they're significant. The kidney problems come in later, on average from the age of 5 onwards, sometimes the beginning a bit earlier, and then pulmonary LAM becomes a problem towards middle life, mostly in women, and we'll say a bit about that as we go through. Next slide, please, Nick. So this is what we knew before 2012, that up to eventually 80% of people over the age of 40 get AMLs in their kidneys, and untreated, the risk of bleeding in that 80% is up about a quarter, well, 25% of those to 50% can have problems. Kidney cancer can occur, but is very rare, but needs to be looked for. Polycystic kidneys, which is another gene on the tip of chromosome 16 with a TSC2 gene, can occur if you have a deletion across the whole tip of the gene and you get both diseases. And that's important because it leads to early blood pressure and kidney impairment. But the actual number of people who end up needing dialysis with TSC is thankfully very low, and nowadays much lower than it used to be. However, prior to 2012, up to about 40% of people had some impairment of their kidney function, and that's important because it can increase the risk of heart disease later in life. So preventing that's important. And anything that affects the kidneys can make you more at risk of high blood pressure. High blood pressure is common anyway, so that's always worth monitoring for in TSC. And then to LAM. So most of LAM comes from the kidneys. The cells break off from the AMLs in the kidney and travel to the lung and seed throughout it. Often that's very minor and not real problem, but it can become a problem for a significant minority of people later in life, but it is very treatable. Next slide, please, Nick. So this is a large AML, and you'll see it's in the middle of the kidney with that huge, great blood vessel going to it. It's a thing with a very fuzzy edge. And that was someone who was having it embolized at the time, but that is what they look like. Next slide, please, Nick. And this is what we now think is the main cause of pulmonary LAM. Sometimes it can start in the lung, sometimes it can travel from somewhere else, but mostly it's secondary to the kidney AMLs. Next slide, please. This is some older data now about when we were keeping, and some of you may have been involved in this, a renal registry at Brighton. You can see that the people in the blue diamonds haven't had any bleeding from their AMLs. And the people in the magenta or pink squares are the people who had bleeds from their AMLs. And it's clear that the AMLs that are getting bigger faster and the bigger AMLs are the ones that are more likely to bleed, but there is a complete crossover. So the only way you can predict it in an individual person is to follow what's going on from year to year. It's very rare for an AML smaller than 3 centimeters to bleed, which is reassuring. Next slide, please, Nick. And this is the data from TSC. TSC was a worldwide study which went on for some years, and we're still finishing writing up a few papers from it. But it was collaborative and very useful. It was sponsored by Novartis, so we have to thank them as well. Next slide, please, Nick. And this was the kidney side. If you look at the bar graph at the top, you can see that on the orange bar on the left, that overall 48% of people had AMLs in the cohort being followed in TSC. And sometimes they began very early. And in a couple of patients, it was less than 2 years old, but mostly AMLs weren't noticed until people were older. So that by the time people are over 40, and this is the blue bar at the right-hand side of the graph, 78% had AMLs. Overall, if you look at that little square at the bottom, you can see that the people with the TSC1 mutation tended to get AMLs later than the people with TSC2 mutations. In fact, they were twice as old, and that meant, of course, that they were smaller and growing less fast. But there was also a crossover in when they could occur. Next slide, please, Nick. But this shows it in a bit more detail. So in TSC, about a third of the patients with TSC1 had AMLs, and the mean age that they were diagnosed was 22, whereas half, was 2/3 with people with TSC2 had AMLs, and their mean age at which the AML was found was 13. And of course, because they're occurring earlier, when the kidney's got a much more growth potential and is more rapidly growing, they tended to get, the people with TSC2 tended to have the bigger AMLs compared to the ones with TSC1, but you still need to monitor people with TSC1 from an early age because it can happen. Also, in the bottom line in that chart, twice as many people with TSC2 had been treated for their AMLs as for TSC1. Next slide, please. But overall, if you look at in the top small letters, you can see that this was another cut of the data. So the figures are slightly different from ones before, but the percentage of people with AMLs but over the age of 40 was over 60%. But the percentage treated in each age group was about half that. So over 80% of people over the age of 40 develop AMLs eventually. Only half of those need treatment and the other half don't. And the only way of finding out who's going to need treatment to prevent bleeding or enlarging is to follow them from year to year. But on the left-hand side, you can see that there was one patient aged less than 2 who needed treatment at that early age, and also one age less than 5. So it's something that you need to check lifelong. Next slide, please, Nick. And now I'm going to hand over to Nick. He's going to talk about the treatments for AMLs and other kidney problems. Thank you, Nick.
Thanks. Thank you very much, Chris. Good evening, everyone, and thank you all for coming. So I'll talk to you about treatment. It's very strange, isn't it, to think that how old some papers are, and Exist 2 is already 9 years old. So time does fly. Of course, back then I was in short trousers, and Chris and John Bissler were the main authors of this paper. EXIST-2 is a large randomized, multi-center randomized controlled trial of 118 TS patients with mostly with kidney angiomyolipomas who were treated with either everolimus, our mTOR inhibitor of choice, versus placebo in a 2-to-1 ratio. So it's something like 97 patients were treated with everolimus and the rest were treated with placebo. And you can see on this headline graph the much improved response with the everolimus group compared with placebo. And this was over the course of 2 years. And it was John Bissler and Chris describe it as a one shot to try and demonstrate proof of principle, really, because we knew by then that that the mutations in TSC 1 and 2 led to mTOR upregulation, which seemed to lead to these benign growths in different parts of the body. And so using the mTOR inhibitor to switch it off was an excellent use of this drug of everolimus. But of course, funding for these things is very difficult to come by. So we had one shot, and that's how they describe it. But using this drug in a sustained long-term follow-up study over the course of 4 years, it was demonstrated that there was a sustained improvement in shrinkage and devascularization of these kidney angiomyolipomas. And this is one landmark study alongside EXIST-1 and EXIST-3. EXIST-1 was looking at brain SAGAs and demonstrated excellent efficacy in that field. EXIST-2 in pulmonary LAM and in kidney angiomyolipomas, and EXIST-3 in refractory epilepsy, all in response to mTOR inhibition with everolimus. So this briefly says that the brain SAGAs are treated successfully with everolimus, kidney angiomyolipomas, also symptomatic pulmonary LAM, also resistant epilepsy. And in addition to that, we have noted that the facial angiofibromas can be successfully treated with mTOR inhibition as well, but we don't yet have funding for that particular indication. And the jury is out on whether or not we can improve TSC-associated neuropsychiatric disorders with mTOR inhibition. But of course, mTOR inhibition is expensive, and we should also remember that that kidney dysfunction in CKD associated with TSC must also pay good attention to the basics, and the basics is looking after blood pressure. There's very good evidence that that poor blood pressure control leads to progression of chronic kidney disease. And therefore, good care involves good blood pressure control to a target average of less than 130 over 80 millimeters of mercury, to be specific. And by controlling it, we can slow down the progression of chronic kidney disease. And a significant barrier amongst our patient cohort, amongst your friends and family, is normalizing taking blood pressure. It's difficult, and if we if this becomes a big thing in the clinic, then we can get perhaps a not very fair picture of what blood pressure really is like. So normalizing taking blood pressure so it's a fair measure of a patient being in a normal environment is an important part of that. And sometimes measuring blood pressure at home is useful. And to address it, lifestyle measures, including a low salt diet, good hydration, good exercise, and then medications. And the common medications we use are ACE inhibitors like ramipril or angiotensin receptor blockers like irbesartan or losartan, calcium channel blockers like nifedipine and amlodipine, beta blockers, and water tablets or diuretics. And there are other medications too. I mentioned lots and lots of different medications, but it's important to talk to your physician who's looking after you about that in more detail. And what about other lumps on the kidney? We've talked about angiomyolipomas and the way that they can be treated successfully with mTOR inhibition with everolimus. But there are other lumps in the kidney that can occur. I just noticed my video froze. Am I still online and talking?
Yes, you are.
Yeah, we can still hear you.
That's a relief. Okay. So yes, renal cell carcinomas are a differential, and this is one of those very difficult diagnoses. So we are very heavily reliant on our radiologist colleagues, our specialist radiologist colleagues, to help us in making the diagnosis as to whether or not this is a kidney angiomyolipoma that we're seeing on the imaging, or whether or not it might be a renal cell cancer. And those renal cell cancers, they are potentially curable. So a significant operation, but potentially curable. And it's the diagnostic uncertainty that is associated with interpreting the scans, which is important to try and address. And sometimes that may involve biopsies and things like that. And many of you may have talked with your physicians about that in the past. There's also some history of the possibility of malignant AMLs. Various case reports worldwide have talked about malignant angiomyolipomas, but these, if they exist, are very rare. So then the question, is this the lumps on the kidney an angiomyolipoma, or is it another kidney tumor? So the differential includes renal cell carcinomas, oncocytomas, or other rare tumors. And we use the appearance as to the amount of fat that's contained in the angiomyolipoma, because the angiomyolipomas are angio, blood vessels, myo, smooth muscle, and lipo, fat. So they're made up of three different components. And it's the fact that they are growing in those three different components which helps to suggest that they are benign rather than one particular vascular tissue, as is very common in more nasty cancers. And also the appearance as to whether or not the tissues are being invaded around it, or whether or not with benign tumors they tend to be pushed out. I won't go into too much detail about that, but essentially we are very reliant on the appearances of the images, and our specialist radiologists around us to help advise us as to what it likely is. And one of our very good friends who's a radiologist is Uday Patel, who published back in 2005 now that a typical AML growth rate would be less than 5 millimeters per year. And another way that we have that we are using to monitor whether or not an angiomyolipoma is an angiomyolipoma is by using mTOR inhibition as a trial treatment. So if it behaves in a way that we expect it to with mTOR inhibition, so becoming less vascular and shrinking in size, then that makes it more likely to be an angiomyolipoma as well. And in that way, we can try and avoid biopsies unnecessarily in our patient group. But of course, we do things depending on each individual circumstance. Other potential TSC associated problems. Chris talked about polycystic kidney disease and the fact that TSC1 and PKD1 and TSC2 sit on the same chromosome. So they're basically neighboring genes. And if we knock one out, then that can have an implication for the gene right next door. And TSC1, PKD1, TSC2, the contiguous gene syndrome leads to lots and lots of cysts in the kidneys. And these can grow, leading to pain, high blood pressure. They can bleed, they can become infected, and they can become bigger and bigger, causing chronic kidney disease. And it's these enlarging cysts that impairs the normal kidney function. And so a key part of managing patients with this particular issue is by good blood pressure control, and to aim to slow down the rate of the growth of the cysts. And one of the key ways of doing this is by drinking lots and lots of fluid, ostensibly to produce 3 to 4 litres of dilute clear urine per day. But in order to do that, of course, that requires lots and lots of drinking. And tolvaptan is a no longer very novel treatment, which helps to reduce, and has been shown to reduce, the rate of cyst growth. We haven't managed to demonstrate that in our PKD1 TSC2 cohort because it's not the dominant cohort, but that would be an interesting question to ask. Thankfully, end-stage kidney disease or dialysis is relatively rare, but is more common in this group than in plain TSC1 or TSC2 patients. And transplantation is another definitive option for these patients too. And there are other cystic kidney diseases. So our good friend John Bissler has provided us with some beautiful images to remind us of the different types of cystic diseases that there are out there that can affect the kidneys in TSC. So here we have, I hope you can see my cursor here, but these multiple small cysts. And in others, we have multiple larger cysts, which can also occur, but they don't make the kidneys enormous. I think there was a fascinating BBC article not so very long ago demonstrating someone's very enormous cysts that were removed out of a polycystic kidney disease patient. But these multiple larger cysts are much smaller kidneys that is characteristic of TS. And then we can get some focal large cysts that may be caused by damage, such as a bleed, and then regeneration of the kidney around it, leading to cyst formation. Or we can get these absolutely microscopic cysts, literally microscopic. So this is a microscopic image of tiny, tiny cysts on the kidney, but we can even see that on the MRI image there, just there. So different types of cystic disease associated with TS. And then chronic kidney disease. So this is where the GFR, or the glomerular filtration rate, basically what the speed and the volume of blood flowing through the kidney at any one time is. And once that drops from above 90 mils per minute to less than 60 mils per minute, then our patients are defined as having chronic kidney disease. And the prevalence of this back in a big GP survey from, I think Chris told this is about 2009, 2008. But back then, the bad old days, I think is how we described it. Back then, the CKD prevalence was about 40%. And the prevalence of or incidence of patients progressing to end-stage kidney disease, i.e. needing dialysis or kidney replacement therapy, was between 1 and 5%. So 1 to 5 in 100 people needing kidney replacement therapy. And there are many possible causes of that. That could be due to repeated bleeds in the kidney, or could be due to surgery. could be due to repeated embolizations to pick out individual growing angiomyolipomas. Could be due to polycystic kidney disease. Could be due to high blood pressure, poorly controlled blood pressure, or to these, and here we go into the not completely definitively demonstrated microscopic angiomyolipomas, potentially reducing the kidney reserve, and then normal aging on a reduced kidney reserve, leading to chronic kidney disease over the course of time. So next we'll talk about the magnum opus, which is the introduction of UK guidelines for managing tuberous sclerosis complex. I hope that all of you will have seen the patient version of this accompanying a beautiful document that was published by the Tuberous Sclerosis Association, really to help make these guidelines totally accessible to both patients and clinicians alike, so that we can ensure that all of our patients get an equivalent standard of care wherever they are in the UK. So these are available to you all, and please do access them if you haven't. And there's the link just down there. But broadly speaking, from our purposes, for kidney monitoring, we need annual blood pressure checks and kidney function or blood tests, an MRI scan preferably. So cross-sectional imaging is important, but of course we do recognise that the MRI scans are not for everyone, and it can be claustrophobic, and sometimes we require a general anaesthetic to undergo an MRI scan, or maybe a CT scan is better because perhaps we've had a vagal nerve stimulator or something like that inserted. Every single person will need an individual solution to that, but we prefer to advise MRI scans 1 to 3 yearly. And if there is a growing angiomyolipoma or a growing tumour on the kidney, then this will be annually. And also to look for a urine dipstick to look for proteinuria and evidence of chronic kidney disease. Lung monitoring. So this is a special scan. I say a special scan. A high resolution CT scan is what it is its official name. High resolution. I don't know. Slightly thinner slices to look very carefully at the pathology of the lung, and this will allow us to elucidate whether or not there is LAM in women aged 18 and men with breathing problems associated with tuberous sclerosis complex, and spirometry in those who have been shown to have pulmonary LAM. And if there's a problem, then we repeat it every year. And if there's nothing, then we repeat the lung CT every 3 to 5 years in women until that's a point of debate. We haven't completely decided when we stop, but clearly at some point between, well, if we base it on our theory that this is an estrogen-driven tumor on the lungs, then we would consider stopping at or near the menopause. But as I say, it's something that we haven't completely got a 360-degree view on. But in addition to this, we've also got to think about monitoring for other aspects of TS, so regular brain imaging, screening for TSC-associated neuropsychiatric disorders, or TAND, and the skin review as well. Funding treatment. So this is this was the other magnum opus, so having demonstrated that mTOR inhibition works with 3 large multi-center randomized controlled trials, getting funding for treatment at a cost of around about £20,000 per patient per year was no easy ask of our wonderful UK government, or whoever was in charge back in 2016 and 2018. Can't remember. It seems like forever ago. But what we do know is that your TSA did quite a lot of work to ensure that this happened. And so the result of that is that we are in the TSC clinics, not just us at St George's, but across the UK, are able to offer mTOR inhibition to for specific funded indications in the setting of TS, specifically for brain sagers, for pulmonary lamb, growing brain sagers, growing pulmonary lamb, growing kidney angiomyolipomas, and refractory epilepsy. But we can offer that to our patients, and we're able to support its treatment. At St George's, as an example, we have a diagnostic clinic once a month, the TSC genetics clinic, and a TSC renal clinic once a month as well. And then a 3-monthly regional MDT where we discuss all of our patients. And in the clinic, we have lots and lots of different excellent minds, in particular, Dr. Chris there. And but we must also mention our TSC clinical nurse specialist. We had to work extremely hard, not just for funding mTOR inhibition, but to get a clinical nurse specialist to help support all of our patients. And we'd say that is probably the most game-changing element of our service, because it allows us to, our TSC clinical nurse specialist allows us to follow up people much, much more closely, and to ensure that the blood tests and the clinic appointments run smoothly, and the imaging is ordered, and to help people when things aren't quite going right, and in a much more direct way, despite patients coming from near and far. And we advocate this model for every single TS clinic across the UK. As you'll know from surfing the TSA website, all of our wonderful colleagues across the UK who've also signed into this little paper that we did, 3 years ago in 2019. The practicalities of mTOR inhibition. This has been even more successful than we ever thought, and there are many reasons for that. But I suppose we mustn't be blind to the fact that there are side effects of any drug that you start, not least mTOR inhibition. And as a growth pathway inhibitor, it slows down the rate at which cells turn over, and therefore it's not a massive surprise that mouth ulcers is a very common side effect. And there are other things too. But we deal with these by fairly proactively monitoring for side effects and adjusting the dose accordingly. And as well as that, we start a much lower dose, 5 milligrams rather than 10 milligrams, as we had in the one-shot EXIST-2 trial. But we have great success in treating kidney angiomyolomas, brain sagers, and pulmonary lamb. And for epilepsy, it works for a proportion, but generally speaking, the sooner we start it, the better. But because we have to run slightly higher levels in order to get efficacy in epilepsy, it isn't necessarily the silver bullet for everyone. And there are roughly 3 monthly visits to hospital, but the advent of the virtual clinic and local blood tests has completely revolutionized this. And whilst COVID-19 is a bit of a dirty word in our clinic, it has really driven the remote clinics and making sure that patients can be monitored virtually and without having to leave their home environment too often, in a way that perhaps wouldn't have happened otherwise. And then to end on the dirty words, COVID-19, what we did. So COVID-19 back in March 2020, we were very, very cautious with Everlimits. We stopped almost everyone's everolimus who were on it for kidney angiomyopomas. But as the first 3 months went past and the first wave passed over us, the worldwide data was very reassuring in that, generally speaking, patients didn't die amongst our cohort, and were recovering. And alongside this, we advocated, of course, social distancing and self-isolation, and that worked incredibly effectively. And then along came treatments and vaccination. We do advocate 5 vaccinations as of, I think it was it 2 days ago that the 5th vaccination was rubber stamped by the UK government, and so we support this. There are, of course, now multiple treatments available, thanks to the enormous efforts of our colleagues at home and abroad, and those at risk, particularly those with significant lung, LAM, and reduced kidney function, can qualify for treatment with via the COVID Medicines Deliveries Unit, or delivery units. These are CMDUs, and if you type in CMDU, if this affects you, into Dr. Google, it will take you to an NHS England website, which gives you a long list of every single CMDU locally to you, and how you'd access it. But generally speaking, it's via your GP, and it allows access to neutralizing monoclonal antibodies, which help to mop up the COVID-19, and also antiviral medications as appropriate. And now that COVID-19 restrictions have been withdrawn and the Omicron variants have been associated with a much milder disease in vaccinated groups, we still need to be wary. There's still significant morbidity associated with long COVID. So we still advocate caution with socializing amongst our immune suppressed patients, but of course we have to balance out the risks and benefits of that for every individual. I think we're all aware of the costs of full isolation for a prolonged amount of time. So we said at the beginning, we're not going to end with a dirty word. We're going to end with a photograph of flowers. So these are some beautiful tulips at the front of St George's Hospital on Dr Chris's way home from our busy clinic back to Brighton. Thank you for your attention, and I think it's time for questions.
There certainly is, yeah. Thank you, Chris and Nick. Those tulips look a lot happier than mine. I must. I think my garden's about 2 weeks behind everyone else. I don't know why. But yeah, that's great. Thank you. Really appreciate it. So let's just get straight into it, I suggest, so then we can get as many questions and answers done as possible in the time that we have. I can see there's a couple of people hands up. The first person I saw was David, so I'll go with David first, and then we can go to the next one. So over to you, David.
Thank you. Well, my first question, I've just got a whole list of questions, but I know I'm not going to get the chance to ask all of them. It was really interesting talk by both Chris and Nicholas. It does relate to COVID, though, and vaccination. I was really interested to see the recommendation about 5 vaccinations. I found it very difficult to get clarity through medical professionals and my daughter's GP about what, as a TS patient on everolimus, she would qualify for, and so far she's just had the first 2 vaccinations and a booster. I'm keen that she gets the maximum amount of vaccine protection that she can. So, I mean, could you just sort of clarify where these guidelines or recommendations stand?
Do you want me to do that, Chris?
Yeah, you start, Nick.
Well, I suppose it's very difficult to say, but I think the important thing is that that for any individual, once you've been vaccinated, it's really like exercising your immune system and reminding your immune system of what the outside of a COVID virion looks like. And I think if those nearest and dearest to you have had 3 vaccines so far, and the last one was over 6 months ago, then to take advantage of the next drive for the next vaccine in an at-risk patient is perfectly appropriate. But I wouldn't be chasing down a 5th when one's only had 3. I would chase down the 4th now that that's become available. I hope that's helpful. What are the guidelines? It's very, very difficult to say exactly what the guidelines have been at any one time. And we have done our very best to try and distill UK government advice versus pragmatism. But speaking as one of the volunteers on the Oxford AstraZeneca trial, back when we were actually a little bit fearful of having vaccines, it was one important shot. It's thankfully demonstrated to save lives. It's thankfully demonstrated to reduce the morbidity associated with COVID as well. So it's well worth doing. But in terms of the precise number, I'd interpret it a little bit more loosely, because ultimately it's just important to be vaccinated and to try and keep your immunity up when one is allowed to do it. I think that's probably as close as I can get to a definitive answer. Oh, Dr. Chris is going to say something even more definitive.
Just a quick word on that. Both this time and the last time, the clarity on who falls into what category of vaccination is evolving. We had to advocate very strongly for patients with severe epilepsy, patients on everolimus last time round, and the government really have a kind of guessing, and their lists are not complete when they start. The fact that everolimus was accepted as a qualifying immunosuppressant last time should count just as much this time. So really your physician who prescribes everolimus should be writing to your GP saying, put them on the list, they need the vaccine, which is what we did for our patients who we prescribed for.
Thank you.
Thank you, David. Thank you for that. So I think the next person was Marie, so we'll go with Marie. Apologies if we don't get through to everyone, but it is excellent to see everyone's keenness to answer questions, so we will get through as many as we can. Over to you, Marie.
I thank you both. Excellent presentation and overview. A bit of a simple question, and apologies if so. I'm aware of what the signs of a catastrophic kidney bleed is, but what are the signs of a low and slow bleed? And what would be the testing or observations that we would need to keep an eye on? Thank you.
Yeah, so it's generally speaking, I think we'd be looking for pain, localized pain, and we'd want to know about blood pressure. If we're chronically losing blood pressure, then the blood pressure when we're lying down and standing up would feel quite woozy when we're standing up. So even without doing the blood pressure, maybe just looking at how someone is between lying down and standing up all of a sudden. But also having regular imaging will hopefully help the physician helping to look after your relative to see whether or not there are any lesions that are likely at risk of bleeding. So that will give us a lot more confidence really about whether or not that was likely to be the case. And that's really the product of all that we've talked about is to get regular surveillance so that one isn't asking these difficult questions and leaving it to the imagination. But yeah, so basically, do they have a good blood pressure? Do they get woozy when they're standing up? Is there significant pain? Is there blood in the urine?
Thank you.
Thank you. Thank you all. Thank you, Marie. So we'll go now to the person who has the funny username. So B3 dash, yeah, over to you. Oh, I think you're muted as well if you want to mute yourself just before. Yeah, I might be able to do it for you.
Yeah.
There we go. Mute you now.
All right. Yeah, my name's Joe. I do apologise for that. It's about the everolimus. We put it on it about 3 years ago. Unfortunately, I had a massive allergic reaction to it, and I'm having to read this off my letter because I can't remember it. It was, they said it was erythema multiforme, and possibly Stephen Johnson syndrome was the reaction that I had to the everolimus. I was extremely ill, all my skin blistered, and of course now my consultants are struggling to find a way of treating the AMLs on my kidneys because unfortunately they're growing. They're now between 4 and 6 centimeters, the biggest ones. And I'm just actually on just to try and get some advice that I can give advice to my consultants. They keep mentioning me going for a skin test and things like that. Hello.
Hi.
Hi. Yeah. Sorry, I suddenly.
That's right. Yeah, we can hear you.
Went blank then. Yeah. So yeah. So as you can imagine, it's I'm now in a position where I can't take the everolimus. They've already said that next time I have the reaction, it could be life-threatening. So they're extremely they're terrified of giving me it. So now we're struggling for a treatment for the AMLs on my kidneys. I'm just wondering about advice.
Well, that is a very a difficult problem, and one which I think that we will struggle to deal with tonight. I think that we are very open to talking with your local team to kind of help you. And I have to be honest that our experience of this particular side effect with mTOR inhibition is not something that I've seen before, but at the same time we're perfectly accustomed to seeing it in other circumstances. And so I thought, Chris, do you have anything else that you want to add?
It might just be worth trying sirolimus and a
That's
test.
what they were. My consultant looked into the sirolimus and the everolimus, and they said that the makeup of them was extremely similar. And because we don't know what part of the medication may have caused the allergic reaction, that they're extremely concerned about.
It's true. It's a question of the balance of risks.
That's it. And
how big the AMLs are, whether they have aneurysms, with how fast they're growing, against the risk of a trial of some sirolimus.
It was such a massive reaction to the everolimus that I mean, supposed to be going for a skin patch test.
Yes, there are allergy specialists who could also advise on that, and how to do a test for sirolimus, or how they would go. And some people who have been allergic to one have been successfully treated with the other. That's why I've mentioned it.
Right.
But get your doctors to get in touch with us, and we'll discuss.
I will do. And I'm back at the clinic for the skin patch test as soon as they can get hold of a tablet of the everolimus, because it's something you just don't have in you. As soon as I couldn't take it anymore, I gave it back to the pharmacy and whatever. So there's Leeds and Chapel Hospital are struggling to get hold of a tablet of it. But I've got a telephone consultation, I think, coming up with them. Mm-hmm. So, but I'll get my renal consultant, to get in touch with yourselves and see what if you can come up with any ideas.
Yeah, no, good idea.
All right.
Great. Thank you, Joe. And if the TSA can help in terms of contact details across to anyone, do just let us know as well. We'll be more than happy to help in that.
All right. Yes, that'd be good. Thank you very much.
No problem. So we'll go to Phil, and then we'll try and go to Joan and see where we are with time after that. So Phil, if you're happy to go ahead.
Hi there. We had a question about the fact that Scotland's a little bit different, and so the mechanism for funding is different. And we're aware that some people with AMLs are receiving everolimus and some are relieving sirolimus, on the basis maybe that local renal physicians are a bit more used to sirolimus, and that the practicalities of drug monitoring for everolimus can be a little bit tricky. And so it's not something that we are at the stage of starting yet, but thinking about, and it's being discussed. And so I was quite interested in hearing, your views on the differences between the two and the magnitude of that difference, if it's why everolimus is your drug of choice.
Oh, well, Chris wants to say. Okay, Chris, you say.
So in terms of efficacy or beneficial effects, there's absolutely no difference. One or the other is fine. Sirolimus is still a lot cheaper. Everolimus is the one that's been licensed, but we used sirolimus for a long time before we used everolimus, and we're still using sirolimus in some patients. And in other countries, sometimes it's only sirolimus, others it's only everolimus. So, but they work just as well. And level of side effects is about the same.
Well, that's perfect. Really reassuring. Thank you.
Good, great. Thank you, Phil. Thank you, Chris. So we'll go over to Joe, who's been waiting a little while. So over to you, Joe.
Thank you, Luke, and thank you, Chris and Nicholas, for the privilege of being able to understand a lot of your research and hard work. We do appreciate that as parents, so thank you for that. I'll try and be brief. My daughter actually, in comparison to some, doesn't actually have quite big AMLs. She has TSC2. She's 17, and because we are actually in North Wales, we get to be seen in Alderhay and Liverpool more often. So they are in the opinion at the moment that once every 3 years is enough to MRI. And what you were saying, Nicholas, about the signs to look for low and slow bleeds, I am a bit concerned because we've been struggling for about 15 months with her, having lots of abdominal pain. And GPs have passed us to gynecologists, have passed us to the bowel specialist locally, who I'm still waiting to see. She's had CT scan and she's had a camera down. And obviously she's still suffering with this localized pain in the abdomen, around the stomach, on the belly button to the left, up above, below the sort of chest area. And it's quite concerning because she is begging for help. It's very, it's chronic pain. I haven't noticed blood in the urine, but she is very woozy when she stands up and lays down. And that was a bit of a trigger to me when you said that, because, I had never connected that with a symptom. So I just wondered what your advice would be, really, whether I should be pushing for, the nephrology to get involved here.
When was the last scan?
Her last scan was on the 30th of April, 2019. The MRI, and I mentioned to them I'd actually had a consultation with Professor Sampson in Cardiff, and And he was, even then, I mean, we're talking back when they were sort of, I think the biggest then was 10 millimetre, whereas it grew in a year, in 12 months, it's gone up to 20 millimetres on one of her kidneys. And he said then that she should be having yearly MRIs. And when I mentioned it, they were, no, you know, we decided it's 3 yearly.
So that's the I think our colleagues in Liverpool have all signed up to the UK guidelines as well. But that is very much the whole point of the Tuberous Sclerosis Association helping us to publicise more widely the UK guidelines. But when we have an angiomyolipoma, which we know was 1 centimetre, has grown to 2 centimetres, you've got very clear evidence that it's growing at a rate, and one would be concerned about the fact that they're growing. I don't know. So I think we'd certainly support getting a further scanning. I don't think we want to get people upset with us. I think the first thing to do is just to demonstrate that that those are the guidelines, and I'm sure that Luke can put the link for those for that up, and that,
thank you.
Yeah, I hope that's helpful.
Chris,
thank
you.
And being a bit more blunt and older, if you don't get satisfaction,
okay, yes.
second opinion is what you need.
Sorry.
So don't be afraid to ask for a second opinion if you're not getting anywhere.
Thank you. Yeah, because obviously, you know, we're living with it every day, and she's not in school, she's not able to go anywhere. You know, she basically can't really walk far, even. It's that bad, the pain. Yeah, thank you for that.
Thank you, Joe. Thank you. And yes, what I'll do, just to make sure that everyone's seen it, is everyone who signed up for tonight's event, I'll reshare the clinical guidelines summary that we developed, and all clinics are aware of that and should have that, and hopefully it will help everyone understand. We're sort of getting a little bit beyond the time now. I can see people are looking. What I'm going to do is suggest we do finish it there, but I am going to gather everyone's questions that are on the chat. I can see Chris has responded to a lot of them, so thank you, Chris. And I think David, and I can see one or two others with their hands up as well, may have had further questions as well. Please do either reply to the email that I sent to everyone, or do email. Your best bet would be to email support@tuberous-sclerosis.org, and then we'll get them as soon as we can. But yes, so hopefully we'll get to them very quickly. But other than that, thank you. Having the number of questions that we've received is excellent. It's really appreciated. It shows the value of this first and foremost, and the more questions that are asked, the more answers that are shared across everyone as well. So this recording will be shared as well, so that people can benefit from it. As I say, I will gather everyone's questions that we put on, and I will share the clinical guidelines just now as well. Keep an eye out for all the other events that we have going on. We have TSC and Epilepsy is our next one with Dr. Sam Amin, which is happening in April. And other than that, yeah, hope you have a nice evening, and just thank you once again to Chris and Nick for tonight as well. So yeah, so thank you everyone.
Yeah. Thank you everyone.
Bye.